So people who don't want to move because moving causes them more pain, VR has been showing a lot of promise in that area. Was being used for depression, and we saw all these ketamine clinics open up, right? And what started happening is that people with differing levels of depression were showing up and they were doing the intervention, and they would leave the patient alone in the room. The first thing that's important, and I train all my trainees, is that when someone comes in, you ask them their preferred pronouns, you ask them how they want to be referred to, because that's already showing them a sign of respect. That's everyone.
Love that. We absolutely ought to be all deserve to be receiving our care in safe and welcoming spaces.
I think, again, this is my personal opinion and it might not be popular, but I just think that
Welcome to the final installment of these deep dive issues on the link between chronic pain and anxiety with Dr. David Cosio. Right, so pain is being taken more seriously, right? And there's this shift towards recognizing pain as the fifth vital sign, which I think is
Mhm.
wonderful. How do you think that is influencing the management of chronic pain and anxiety?
So I think it was an intervention that was a good idea. And I think, unfortunately, with all good ideas, it wasn't implemented probably in the best way.
Mm.
What I find is when you have someone come into your office, if they have pain, if pain is affecting them negatively in their life, you're going to hear about it. They're going
Mm,
to tell you.
absolutely.
But if you start asking questions about it, people will endorse having pain when it's not affecting their life
Mm,
in a way. And so what happened is that it pulled all these people into the, well, if they're asking about it, there must be something wrong when
mm,
maybe they were coping with it just fine.
mm,
And so I think that it kind of made that more problematic. However, that being said, I
mm.
think it's wonderful that we ask
Yeah.
because we weren't asking before.
Yes.
And, if we're asking and people are in distress, then they need support. But I think sometimes that just by asking them, it implies that there's a problem
Yeah,
if they have it, right? And so
absolutely.
then they become worried, and then it kind of creates this like I need to do something when maybe they have pain, but they're adjusted to it and they're coping with it perfectly fine.
Yeah. So, David, what sort of emerging trends or innovations in pain management most excite you in terms of having the most promise for managing chronic pain and anxiety?
So in the last 10 years, what I've really seen kind of starting to pop up is the use of like virtual reality.
Mm,
So, with people, I personally feel like it's really helpful for people who are kinesiophobic. So, people who don't want to move because moving causes them more pain. VR has been showing a lot of promise in that area.
wow.
I also think the use of apps, technology. So, you mentioned mindfulness-based apps. But there's, apps for PTSD, there's apps for
Mm,
pain, there's ACT apps.
mm,
And again, they're helpful if you
yeah.
actually use them,
Yeah.
right? Just because you have it on doesn't mean it's going to
Yes.
fix the problem. And then, I pointed to my watch because it's a wearable technology. I really feel like wearable technology has been very helpful
Yeah.
in my own personal life. I
Yeah.
have an app on my iPhone that tells me when I'm in distress. And when it tells me I'm in distress, I know that I have to stop and I have to breathe, and then the
Yes.
distress kind of lowers.
Yes.
And so I think the wearable technology, the use of telehealth, the apps, the virtual reality, I think that technology is really moving forward in what we're doing right now. Other than that, I would say that in the last 20 years, what we've been doing with pain management hasn't changed much. It's more about the delivery of those things. Yeah.
Yeah.
Mhm.
Absolutely. And touching on psychedelics a little bit more, David, we
Okay.
mentioned them earlier.
Yeah.
Just give me your sort of insights into sort of what you think are the pros and cons of psychedelics when managing pain and anxiety.
I think, again, this is my personal opinion and it might not be popular, but I just think that what we tend to do in medicine is we tend to focus on the worst case scenario or that one particular patient with a difficult situation, as opposed to really focusing on the general population and the needs of the general population, right? What happened, I'll give you an example and why I feel the way that I do. Here in the States, ketamine was starting to be used. I think I mentioned this before, but I'll do it again. Was being used for depression, and we saw all these ketamine clinics pop up, open up, right? And what started happening is that people with differing levels of depression were showing up and they were doing the intervention, and they would leave the patient alone in the room while they're on a ketamine treatment. So there's definitely difficulties there, right? Patients
Yeah.
don't necessarily have a good experience and need support. There was
Yeah.
nobody there. They were giving people these treatments that were not in severe levels. They just had depression. And there are other standardized treatments for depression, psychotherapy, there's the psychotropics,
Yeah.
there's even electrical the ECT that has, some support for severe depression. So my anxiety about using psychedelics is, are we using them the right way?
Mm.
And are we using them with the population that it's intended for?
Yeah.
If you have an untreated or you know, a depression that's not responding to anything, yeah, I think that
Yeah.
that it could be an option,
Yeah.
but not for the person who's having their first depressive episode, who
Yes.
hasn't spoken to a therapist, who hasn't seen a psychiatrist,
Yes.
right? That not that person. But I fear, and from what I've seen already, that they're marketing to everyone, not to a specific.
Yeah.
And again, here in the States, it's because healthcare is a business,
Yeah.
right? And
Yeah.
in Europe, it's a little bit different, and they may use it a little bit differently. But the anxiety comes with what I've seen them do so far.
Yeah.
So is there a place for it? Yes. It should be used with those cases that don't respond to any kind of, standard treatment. And they need to be monitored, and they, very closely monitored. It's not something that you could just put someone on and then 6 months later
Yeah.
see them again. They
Yeah.
need to be monitored closely. And I haven't seen that happen,
Absolutely.
unfortunately.
And forgive my naivety, David. Magic mushrooms, so they fall into the psychedelic category.
Mhm.
Yeah. So there was definitely talk, well, I can certainly say in the UK around
Mhm.
psychedelics, to be very clear, they absolutely do not fit and slot into any of our pathways currently. But there is a suggestion, or has been a suggestion, that actually there is an argument to say that exposure to one off or two off treatments of magic mushroom or psychedelic type therapy to sort of reset the brain versus longer term antidepressant therapy, which, dare I say, increasingly is sort of demonstrating longer term outcomes for patients that perhaps weren't fully considered, be it taking a long time for patients to come off or longer term impact on neurotransmitters and so on. So there's definitely, there's, as you say, I'm in agreement that they need to not be sort of too relied upon or featured too early on. But I think there
Right.
definitely needs to be further discussion
Yes.
around where and how they slot in. Absolutely.
There is an appropriate place for it. I
Indeed.
absolutely think that there is.
Yeah.
I just been in the system long enough
Yes.
where a new thing comes out and it becomes the popular thing and they do it on everyone, and it's like, "Wait, wait, wait. This is not that kind of treatment. You have to be very careful." But
Absolutely.
absolutely, those examples that you gave, like somebody who's been on treatment for a very long time, who's not responding to it anymore, then yeah, those are options. And I've heard the exact same thing that you said, is that it's helpful for resetting, right? My concern is that you're now becoming dependent on something, and the
Yes.
person is not has any kind of internal coping process. And so if we have them go through the traditional treatments first, then I would feel a little bit more comfortable that the person would have some inner coping strategies along with this treatment that's being used, versus just giving them this treatment and they have nothing else to use, right?
Absolutely.
Right.
Absolutely. And then you also recently published an article, David, regarding creating a welcoming clinic for transgender and gender diverse individuals. Tell us more
Yes.
about some of the recommendations for this particular patient group, particularly in terms of treating pain.
Yeah. So what I found working in pain is, there's a pretty large non-binary transgender community
Mm,
that comes with pain management, and a lot of it is, the way that I think about it is that when people start doing gender affirming care, these are things that the average person goes through during puberty,
mm,
and there's these growing pains that occur. But now these individuals may be much older, past, puberty, past, their 20s, and they're transitioning. And so there's a growing that occurs that may have pain depending on, what direction or how they're transitioning, right?
Yeah.
Um, the first thing that's important, and I train all my trainees, is that when someone comes in, you ask them their preferred pronouns, you ask them how they want to be referred to, because that's already showing them a sign of respect. That's everyone, right?
Absolutely.
There are things though that you can do to indicate to someone that you are welcoming, right? So, there's lanyards that have the pride flag on them. There are stickers that you can put on your door that says that you are a safe place.
Lovely.
There's pins that you can put on with the pride flag, just as a way
Yeah.
of letting people know you're safe here, right?
Yes. How lovely.
There also needs to be policies in place, right? And so making sure that any kind of paperwork you have is not heteronormative, or that it's inclusive in the language. There are practices that you can do in the physical exam room, right? So if someone is binding, is not, asking them if it's okay for you to remove the binding, how they want to handle the binding, right?
Yes.
Specifically are individuals who are transitioning specifically from female to male.
Yeah.
Having a pelvic exam can be very distressing. And
Absolutely.
so making sure you have a relationship with them, taking it step by step. They're just things that we need to be mindful of as opposed to when you're dealing with the general population.
Yeah.
And then having some understanding about gender affirming care. Here in the States, people hear gender affirming care and they just assume that means surgery. And that's
Mm,
not what that means, right?
mm.
It could be as simple as someone wearing a binding, or
Yeah.
it could be as simple as somebody wearing feminine clothing underneath their biological sex clothing,
Yeah.
that you wouldn't see unless you do a physical exam. And if you do, not making a big deal about it,
Yeah.
or having a discussion with the person.
Yeah.
And so it's knowing that gender affirming care, there's a range. There's
Yeah.
surgery, but then there's also common things that can be done, right?
Yeah. Love that. We absolutely ought to be all deserve to be receiving our care in safe and welcoming spaces. So I
Expo-
love that.
yeah.
David, thank you so much. That brings us towards the end of our discussion, but it's been an absolute pleasure to speak with you. Good luck with all your amazing work. You absolutely need to be writing a second book. Is there one in the pipeline?
There is actually.
Excellent.
So that makes me laugh because I am in the process of writing my second book. It's going to be called The
Fantastic.
Psychology of Pain Relief. So it's the
Wonderful.
second volume of the first book. But this book will be more catered towards providers. The first book was catered to everyone,
Yeah.
so that the common person could pick it up and understand it. This is more written in the perspective of a provider, and it's going to be kind of like a textbook for like
Love
school.
that.
So that's supposed to be coming out in October of
Brilliant.
this year. So you can look out for that. And again, it's
Love
going to be the psychology of pain relief.
Lovely. Will I get a discount or
No, I don't know. I don't know any of those details yet, but
one
they
to look
called it
out for.
a textbook, so that always makes me a little
Right.
nervous, right? The first book's like $10, 10 American dollars. The textbook makes me a little nervous. It's gonna be a little more. Yeah. Yeah, absolutely. Yeah.
Oh, David, thank you again for your time. Have a great rest of your
Thank you
day.
for this opportunity and good luck with you as well, Catherine.
Thank you so much.
All right.
Stay tuned for the upcoming deep dive episodes where we delve further into chronic pain and anxiety. Thanks for listening.